English. There will be presentations in both Bahasa and English, so please make sure to select one of the languages that you prefer. Otherwise, you will only get the original sound. We'll have some polls to keep you engaged, and we welcome for you to ask questions through the Q&A function whenever you like throughout the presentation, throughout the discussion. The audience is muted during the presentations, but you'll also be able to raise your hand and ask your questions in person during the Q&A session as well. So as I said, I have the pleasure of co-moderating this session. I'm delighted to introduce Pak Ajir from P2JK, who is going to be co-moderating with me. Pak Ajir, would you like to do the introductions?
Ya, thank you Sayaka, terima kasih Sayaka. Perkenalkan Bapak Ibu sekalian, saya Ahmad Aflazir dari Perhitungan Biaya Kesehatan Pusat Pembiayaan dan Jaminan Kesehatan. Suatu kebahagiaan dan kehormatan bagi saya untuk mendampingi Sayaka pada pagi hari ini sebagai komoderator di webinar global terkait dengan Public-Private Partnership. Dan saya ingin menyapa kepada yang terhormat Ibu Kalsum Komariani, Kepala Pusat Pembiayaan dan Jaminan Kesehatan, kemudian kepada para pejabat tinggi media dan pratama dari Kementerian Kesehatan yang sudah bergabung, dan teman-teman dari Kementerian Kesehatan, teman-teman dari sektor swasta yang telah bergabung dari kementerian lembaga lainnya. Terima kasih untuk kehadirannya pada pagi hari ini. Agenda kita pada pagi hari ini sangat-sangat menarik Bapak Ibu sekalian. Seperti yang telah kita ketahui bersama bahwa saat ini PPJK sedang membuat guidance terkait dengan kemitraan pemerintah dan swasta. Dan pada pagi hari ini kita akan mendengarkan beberapa pengalaman global seputar terkait dengan kemitraan pemerintah dan swasta dan bagaimana cara sektor swasta, sektor di luar pemerintah dapat membantu mengatasi banyak tantangan yang dihadapi saat ini, apalagi pada masa pandemi global COVID-19. Seperti yang sudah disampaikan oleh Sayaka, kami juga menyediakan penerjemah Bapak Ibu sekalian secara simultan bahasa Inggris dan bahasa Indonesia. Bapak Ibu dapat terlibat secara langsung, lebih mudah untuk melakukan mengajukan pertanyaan pada sesinya, kemudian tidak perlu untuk ragu bertanya dalam bahasa Indonesia. Saya akan menyampaikan pertanyaan yang Bapak Ibu bisa sampaikan kepada para pembicara. Mengawali acara kita pada pagi hari ini, kita akan mendengarkan sambutan dari Kepala Pusat Pembiayaan dan Jaminan Kesehatan kepada Ibu Kalsum Komariani. Kami persilakan.
Terima kasih Pak Ajir. Please allow me speak in bahasa. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good afternoon and good evening for everyone. Yang saya hormati para pejabat di lingkungan Kementerian Kesehatan, Direktur Kesehatan dan Gizi Masyarakat Bappenas, Direktur Pengelolaan Dukungan Pemerintah dan Pembiayaan Infrastruktur Kementerian Keuangan, Sekretaris Direktorat Jenderal Bina Keuangan Daerah Kementerian Dalam Negeri, Direktur Sinkronisasi Urusan Pemerintah Daerah 3 Kementerian Dalam Negeri, Kepala Lembaga Kebijakan Pengadaan Barang dan Jasa, Asosiasi Dinas Kesehatan, Asosiasi Rumah Sakit Swasta Indonesia, Persatuan Rumah Sakit Indonesia, perwakilan dari sektor swasta, lalu perwakilan dari mitra pembangunan, dan para narasumber dari internasional. Pertama-tama, marilah kita mengucapkan syukur kepada Tuhan Yang Maha Esa karena kita dapat berkumpul dengan kondisi sehat dalam webinar kemitraan pemerintah dan swasta di bidang kesehatan. Ini adalah sesi praktik, ini adalah seri best practice dari pembelajaran global. Tentunya kita berharap pertemuan ini bisa memberikan penambahan pengetahuan kita ya tentang kerjasama pemerintah dan swasta. Dan seperti ketahui, pembiayaan kesehatan adalah salah satu subsistem dalam sistem kesehatan nasional yang sangat penting karena akan membiayai seluruh kegiatan pembangunan kesehatan di sebuah negara ya. Khusus di Indonesia, pembiayaan kesehatan di Indonesia tentunya sejak adanya penyelenggaraan jaminan kesehatan nasional terjadi peningkatan ya, terutama pola belanja out of pocket secara bertahap menurun sejak dijalankannya JKN, di mana masyarakat lebih melakukan belanja dengan sistem jaminan kesehatan. Untuk pembiayaan kesehatan ini yang harapannya tentunya bisa terus meningkat agar bisa mencapai tujuan pembangunan kesehatan, yaitu meningkatnya derajat kesehatan di Indonesia ya. Dari sisi pemerintah sudah ada regulasi yang mengatur bahwa anggaran kesehatan di tingkat pusat adalah 5% dari total APBN dan di tingkat daerah adalah 10% dari total APBD ya. Tentunya ini sudah berusaha dipenuhi oleh pemerintah baik di pusat maupun di daerah ya. Dan untuk pengembangan pembiayaan kesehatan ini juga dilakukan terus-menerus ya. Di dalam rencana strategis Kementerian Kesehatan saat ini salah satu indikatornya adalah bagaimana pengembangan skema pembiayaan kesehatan yang melibatkan pemerintah dan swasta ya. Dan tentunya ini dalam komitmen global, kegiatan ini akan melibatkan kerjasama pemerintah dan swasta dan sangat mendukung untuk pencapaian target-target SDGs ya di dalam pelaksanaan kemitraan pemerintah swasta ini. Sejak adanya pandemi COVID, tentunya ini memberi pelajaran yang berarti ya, sehingga penguatan sistem kesehatan nasional termasuk penguatan subsistem pembiayaan kesehatan ini menjadi penting ya. Untuk itu pemerintah sudah melakukan beberapa penguatan atau inovasi dalam pembiayaan kesehatan ya. Dan ini salah satu caranya melalui mobilisasi dan memilah atau memetakan sumber-sumber pembiayaan ya. Baik untuk program penyelenggaraan upaya kesehatan perorangan maupun upaya kesehatan masyarakat. Bapak Ibu yang saya hormati, seperti diketahui Kementerian Kesehatan telah menerbitkan Peraturan Menteri Kesehatan Nomor 40 pada tahun 2018 yang berupa pengaturan untuk kemitraan atau kerjasama pemerintah dan swasta dalam bidang infrastruktur ya. Dan pemanfaatan sektor swasta ini terus berkembang untuk melakukan pembangunan infrastruktur ya. Namun juga kita harus memikirkan bagaimana kemitraan pemerintah dan swasta ini dalam bidang non infrastruktur ya. Yang sudah berjalan tentunya di Indonesia sudah banyak terdapat pola-pola kemitraan ini. Namun sekali lagi untuk kemitraan pemerintah dan swasta tersebut belum ada regulasi yang mengaturnya. Untuk itu Kementerian Kesehatan didukung oleh HP Plus dari USAID saat ini sedang melakukan finalisasi dari peraturan menteri tersebut ya. Jadi proses penyusunannya sudah berlangsung sekitar 1 tahun antara Kemenkes didukung dengan HP Plus dan juga stakeholders lainnya untuk diterbitkannya Peraturan Menteri Kesehatan tentang kemitraan pemerintah swasta dalam non-infrastruktur ya. Dan terkait dengan hal tersebut, memang kita sangat membutuhkan berbagai masukan ya. Jadi istilahnya seiring dengan persiapan implementasi kerjasama pemerintah dan swasta dalam non-infrastruktur, penting sekali kami untuk mengadopsi, melaksanakan peraturan tersebut ya, dan tentunya memanfaatkan melalui pertemuan-pertemuan yang saat ini mungkin dilakukan dengan virtual meeting untuk belajar pada keberhasilan dari negara-negara yang sudah mengembangkannya. Jadi momen webinar kali ini memang khusus kita ingin mendengarkan berbagai lesson learn dan best practice dari beberapa negara yang nanti akan disampaikan oleh international speaker untuk menyampaikan bagaimana memulai kerjasama pemerintah swasta dan bagaimana masalah tantangannya dan kita ingin mempelajarinya. Jadi melalui mekanisme pertukaran informasi ini kita akan mendapatkan contoh-contoh konkret ya, dan pada webinar ini memang hadir dari perwakilan swasta juga selain dari pemerintah agar sama-sama belajar dan mendengarkan ya. Itu saja barangkali yang bisa saya sampaikan. Saya mengucapkan apresiasi dan terima kasih kepada international speaker yang akan memaparkan materinya pada webinar ini, yaitu pada Amrita Agarwal, Dr. Ades Chaturvedi dan Monisha Ashok dari India dan Washington ya. Terima kasih sudah memberikan waktunya pada pertemuan ini, dan juga kami mengucapkan terima kasih untuk dukungan yang terus-menerus dari HP Plus dari USAID ya. Dan terima kasih pada kehadiran Bapak Ibu yang sudah hadir memenuhi undangan kami dengan mengucapkan Bismillahirrahmanirrahim. Temuan webinar kemitraan pemerintah dan swasta secara resmi dibuka. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Bu Yani atas sambutan dan pembukaan dari acara kita pada pagi hari ini. Bapak Ibu sekalian, saya ingin mengingatkan kembali, Bapak Ibu bisa memilih bahasa di terjemahan nanti. Jadi ada penerjemah yang sudah siap sedia, jadi di layar Bapak Ibu sekalian di bawah itu ada pilihannya nanti, silakan dipilih di situ. Kemudian sebelum kita memulai materi pada pagi hari ini, kita ingin meluangkan waktu sejenak Bapak Ibu sekalian untuk mendapatkan gambaran mengenai seberapa besar Bapak Ibu sekalian terpapar terkait dengan konsep kemitraan pemerintah dan swasta. Nanti di layar Bapak Ibu sekalian akan muncul jejak pendapat, pertanyaan. Silakan host. Pertanyaannya adalah, apakah Anda memiliki pengalaman dengan kemitraan pemerintah dan swasta di bidang layanan kesehatan? Jadi pilihan jawabannya, ya, saya mengetahui aspek-aspek KPS dan pernah memiliki pengalaman. Kemudian, ya, saya mengetahui aspek-aspek KPS tapi belum memiliki pengalaman. Kemudian, jawaban selanjutnya, saya pernah mendengar tentang KPS tetapi belum sepenuhnya paham. Kemudian yang terakhir adalah saya baru mendengar istilah KPS. Mohon Bapak Ibu sekalian bisa meluangkan waktu sejenak untuk memberikan jawaban dari tanggapan pertanyaan yang kami ajukan. Karena ini untuk menilai kita semua yang hadir pada webinar ini sudah seberapa paham atau sama sekali tidak paham. Silakan Bapak Ibu sekalian.
Great.
Ya, saya kembalikan
Looking
over to
forward
you, saya Kak.
Yeah, looking forward to having everybody submit their poll answers. Yeah, we have I think we have close to 100 people on the line, Pak Ajer. So that'll be very exciting to see what the distribution of the answers are going to be. I know that P2JK, HP Plus has had a chance to work with many of the stakeholders on PPPs through the technical guideline development. But let's see if what audience members can say about PPPs. And it's okay if you don't know. The whole point is that we're learning today.
Yeah.
So maybe we'll give you another 10 seconds or so to submit your answers. Make sure to click the submit button on the bottom. And let's see, maybe it's about
silakan
right.
Bapak Ibu sekalian yang belum mengisikan pollingnya.
Great. So maybe we'll close the poll right about here, and hopefully we can get the results up on the screen for everybody to see. Let's see. Mas Adit, do we have the poll results? Maybe I'm the only person who is not seeing the results. Apologies. It seems I'm having a little bit of a hard time seeing the poll results right now. So maybe we'll hold off on the poll answers right now. But I think with the number of folks on the line, close to, I think now a little over 100. Oh, there we go. We have the answers to the poll right now. I hope everybody can see it. It seems like, it's a pretty nice mix over here. We have some who, about a quarter of the audience, who know it very well. Maybe you've done it before, which is fantastic. Maybe you would have some insights to share during the Q&A sessions on your experience, how it compares and contrasts to some of the examples that we would have today in the presentations. And a good number of you also have heard about it, and is very intrigued by it. And we welcome all of you who have heard about it, but not really familiar. And we hope that this webinar would be a good opportunity for you to learn about public-private partnership in various forms. This is very, and many in the audience have engaged through this last year with P2JK in the technical guideline development process. So hopefully some of these topics will relate. Just to give a little feature, really the technical guideline provides guidance around implementation steps, what the process should look like, what kind of institutions, systems should be established along the way as well. And so that hopefully is a really good segue into our first international speaker. I'm pleased to introduce all of you to Amrita Agarwal, who is the National Lead for Health Systems in India for the Bill and Melinda Gates Foundation. I think it's worth noting that India has a similar devolved government system with national level government setting certain policy direction, but also significant authority and responsibility placed to state government, so very similar to the national and the district government, and to some extent provincial government in Indonesia as well. So Amrita has been involved and provided guidance around the health system policy reform at the national level, including engaging the private sector in this policy reform. She's here today to share her thoughts on what has worked and what are the lessons learned from India's almost two decades in rolling out, or over 2 decades that India as a country has been rolling out PPPs in health. So we hope her presentation solicits many questions. Please do use the Q&A box to ask questions along the way. We'll have a few minutes after her presentation to answer them, so do keep them coming. And of course, in Bahasa as well, please make sure to select the interpretation button on the bottom and select Japanese if you would like to hear it in Bahasa, and English for original speaker. Amrita will be presenting in English. So welcome, Amrita.
Hi, thank you, Sayaka. Thank you, esteemed senior officials and ministers from the government of Indonesia, and the various participants who are here present in the webinar. I really appreciate the opportunity to present and share some of the experiences and lessons and learnings from our country of India. There are many similarities across India and Indonesia, and this platform provides an opportunity for us to learn from each other. I also look very forward to learning about the Indonesia system and the questions which may emerge from the discussion. Thank you so much for having me here. So in today's session, I'm going to talk about some of the context of what the private sector health participation has been in Indian context. So what is the background? What is the nature of the private sector in India? I will talk about the challenges of the PPP engagement in Indian context. I will also talk about a few of the critical examples in the Indian context, which I believe are the starting points how PPPs could be done well, and provide a good platform in future for India to really shine in the PPP space for healthcare. These are all nascent examples. These are small beginnings for our country, but I think these are promising areas for India to develop on. But in the end, I will conclude with what India could do better to really foster a very constructive ecosystem for PPPs. We are very much in the journey of strengthening the PPPs. We are not, I would say, a very successful country, but there are some efforts and some examples we're continuing to build on. So moving to the next slide. The context of private sector in India in healthcare is that it is one of the most dominant players. So before 1990s, the healthcare system was largely provided for by the government system. But post the economic liberalization, the private sector has grown rapidly and is now the dominant player across all segments: pharmaceuticals, medical devices, labs, pharmacies, hospitalizations, primary care. And this is true not only for the urban population, but even to a large extent for the rural population. Many times private sector is often the preferred provider and preferred access point. Having said that, the private sector in India is extremely fragmented. And it's extremely diverse and varied in terms of the formality levels, in terms of the models which are being driven, performance and quality. The sheer fragmentation of the private sector poses a great challenge in terms of transparency, efficiency and stewardship. It also poses a challenge in terms of bringing investments into the private sector to strengthen and scale the capabilities of the private sector. So apart from the pharmaceutical companies and large hospitals, the private equity and other investments in healthcare is limited still. and the access to debt and low cost debt to the bulk of the fragmented and subscale private sector is also limited. So these are big challenges in terms of improving the capacity, capability, and the quality of the private sector, really. Private sector is an innovation engine in India. We look at many of the low-cost innovations, which has been able to really reduce the cost of delivery, and which is very important in a low-income country like ours, has been done through the private sector. And we have Narayan Hyderale, Arvind Eye Care, global case studies now, which show that how low-cost innovation can be driven in the private sector in India. Now, when it comes to engagement of the government with the private sector, it has been limited. Largely, the private sector has been financed out of pocket till now. There are government-sponsored insurance schemes, and we have the new one, which is Pradhan Mantri Jan Arogya Yojana, the PMJY, which is the new national scheme for the low-income population. But by and large, if you look at the amount of funding, most of the revenues for the private sector come from not the government. The other challenge is that there have been focus on PPP for infrastructure and for services in the past in India. Across state level, many state governments have tried it, but they have been more tactical and they haven't fully scaled up. They've been done for both strengthening the public system delivery as well as enabling the private sector in the large cities, but there continues to be a challenge in scaling up those infrastructure and services PPP models. Partly because of lack of funding, also because of lack of state capacity to really oversee and manage the PPPs effectively. Lastly, I would say, private sector comes with its own challenges. And there's a lot of mistrust between the public and the private sector. And while private sector has a lot of innovation, there are a lot of market failures as well. And potential for consumer protection to be strong is very high. And regulation is a critical element to sort of get the best of the private sector while addressing the worst. However, that again continues to be a challenge area. We have under regulation in some areas and we have over regulation in some areas. Also, the regulatory powers and policies in India are fragmented across many ministries and across the national level and the state level. Because of the fragmentation, it's been hard to have a holistic overview as to the policies and regulation vis-a-vis the private sector. So this is the context of the private sector in health in India. It's a challenging environment, and there is a lot to be done to sort of bridge the public-private sector divide even in India. Going to the next slide, please. What I will do in this session is try to highlight 4 examples, concrete examples from the Indian context, which are a good beginning to bridge this public-private sector divide and to bring the best of the both worlds to support each other. These are, I would say, still in works in progress, and the full impact of these platforms and institutions are yet to be seen. But they are good beginnings, I would say. I'm not going to talk about the infrastructure PPPs and services PPPs, but these are more strategic public-private partnership institutional platforms, which could lead to a big impact in how the 2 entities really cooperate with each other. So the 2 examples are going to be around policies and catalytic support from the government of India at the national level, the Niti Aayog and the National Health Authority, which executes the PMJY low-income coverage for the 500 million population of India. There's going to be one example from tuberculosis on creating operational support platforms for private sector. And lastly, there's one example on the innovation platform, which encourages research and development in India by bringing academia, private sector companies, and the government together to really support research and development for not only health, but for other sectors as well. So moving to the next slide, please. So the first concrete example we will talk about is Niti Aayog. So as I had mentioned that there is a public and private sector divide, and in the past there has been very little policy dialogue between the Ministry of Health, government, and the private sector. Partly because there is no department of private sector within government of India. There is no one responsible for private sector or for population health. The past efforts for Ministry of Health at the national level has been to manage its own public delivery system. And also, as I had mentioned, the government policies on private sector in health across pharma, medtech, hospitals, outpatient is fragmented across ministries at the national level, but also a lot of it is fragmented with devolved to the state level and to the local level. So it has been very hard for any structured policies and conversations between the fragmented public sector and the fragmented private sector. At the national level in 2014, when the new national government came into power, they set up a premier think tank of Government of India, and the name Niti Aayog means transformation. So this body was put into place to help bring dramatic transformations across sectors. And this body has played a critical role, or is beginning to play a critical role in transforming the health dialogue more broadly for systems reform, but also for public-private engagement. Because it is an interministerial entity, and it can have a policy dialogue across ministries at the national level and also at the subnational level with state governments. It is able to bridge that fragmented divide and be a platform to engage with the private sector. It has, in the last few years, already proposed many policy reform which has impact on the private sector and has been engaging with them actively. Now, the full impact of these policy reforms will bear out in the next few years, but this is a beginning which needs to be seen. So some of the important policy reforms they have championed has been the setting up of an independent national health authority to oversee, and this is an autonomous body, to oversee purchasing of hospitalization care from the private sector, which is the PMJY scheme. So that was championed by Niti Aayog. They've also championed the reform of medical education and medical professional regulation in India. And this was a self-regulatory body by the private sector earlier. And this has been reformed, championed by Niti Aayog, and it has come into, the bill has been passed by the parliament, and the new entity, which is the regulation for the private sector, has now come into being. I will not talk about many other of the examples. They have also been championing and talking to investors to see how more investments can come into healthcare as well. So the potential for this platform is to create other key institutions like NHA, National Health Authority, and NMC, the National Medical Commission, which will further foster the PPP ecosystem, and also to become an engagement platform itself to foster the dialogue between private sector and the many departments of the government. Next slide, please. So, similar to Indonesia, which is a very large effort to cover all of Indonesia, we have a program PMJY to cover not all of India, but the low income 40% of India, which is called PMJY. So the national entity which is executing this program, National Health Authority, has been set up only in 2018. It is an autonomous body set up to implement PMJY at the national level, and it has an independent governing board chaired directly by the Union Minister of Health. So there are two different ways in which NHA, the National Health Authority, is engaging with the private sector to create a PPP ecosystem. One is through directly purchasing services from the private sector and the public sector. And through that purchasing mechanism, looking at onboarding, training, looking at fraud management, quality control, many of the typical purchasing influences with the private sector. But the other role which it's trying to play with the private sector is more of a catalytic role. Because there is very limited data, research, and evidence with respect to private sector, which is very fragmented in India, NHA has become a platform to try and get more information about the private sector in India. So they use their own customer call centers, they use their partners and state agencies and their transactional data to create a picture and policies about and inform the policy dialogue on private sector. They've also been trying to foster innovations. So India has been seeing a lot of innovations in the private sector, but one of the challenges has been for the innovations to scale up and go to market. And that has also been because the government procurement system for new innovations is challenging. It's typical for governments to purchase the tried and tested products and not necessarily the new innovations because of the government norms. So they have started this market access program in which they do grant challenges, they invite proposals, they get a committee set up to shortlist proposals, help and facilitate them with pilots in the state level, help them through the certification process, and link these new innovations with the government procurement systems. This is a very important program because India is a resource constrained country. We need to lower the cost of care for our country at the same time improving quality. So we need to increase innovation to be able to do that. And NHA sees itself as playing a facilitation role through that. So it's not about them directly financing it, but them facilitating faster innovation. They've also been exploring how to unbottleneck other barriers for the private sector. For example, in rural areas or in smaller cities, private sector has a tough time with getting financing, access to debt. And with COVID, that has become a big problem. So they have been in conversations with large government banks and with other entities like USAID and us for having blended finance opportunities to support the small hospitals in smaller towns and rural areas. They also have partnerships with commercial insurance regulator so that there will be information exchange between the IRDA, the Insurance Regulation Development Authority, and themselves in terms of setting fraud management processes and databases so that they can learn from each other and support each other. So that is an important way NHA is trying to play a larger catalytic role beyond its purchasing role in shaping the ecosystem of healthcare. Moving to the next slide, please. This is an example of how to support the private sector to do its care management better. So in India, TB, tuberculosis is one of the largest disease areas which is burdening us. And with 70% of the outpatient care being in private sector, there has been very low level of notification and engagement in the past or correct treatment for the population for TB. This has been a big problem. So the government is now trying to launch a program at the national level, which will support private primary care providers to be able to treat the TB patients better. This was piloted first in 2014, And for the last few years, the pilot has demonstrated that if you provide private providers, a shortlisted set of private providers with access to government diagnostic high-end equipment like Gene Expert, with some vouchers for drugs which the doctors can then share with their patients, and with some support for patient adherence programs, this will lead to doctors being more accountable and engaged in the TB treatment. Also, it leads to better stickiness of relationship between the patient and the provider. And this has led to better treatment. It has led to more notifications on TB. And basically, this program is now being rolled out at the national level by the national government. Also, it is being tried as a model for other disease areas, for hypertension and for HIV. It is a little bit of a expensive resource program, but versus outright purchasing primary care, which is a very expensive proposition, this is a hybrid option in between to engage the private sector partially. Moving to the next slide, please. The last example is really about upstream innovation and research and development. CSIR is a government autonomous body under Department of Science and Technology, and its remit is not only health but other areas of like energy and many other areas. And its remit is to spur innovation. NMITLI is a specific program within this government autonomous body of CSIR, and it was set up in 2000 to specifically move away from this model of supporting incremental innovation and how to create a catalytic environment where India could spur high risky investments in innovation, which could have a huge global gain and could spur India into the global leadership forum in whichever areas are of national interest. So the way NMITLI works is really to create a reverse risk investment profile. So they take the upfront risk and they help create the market, and they get the academia to work closely with the corporates and the companies, so that the innovation can not only be funded but can also be licensed, commercialized, and scaled up. And they play a catalytic role to sort of make that ecosystem function. It's not a passive body where they receive only proposals. They also prioritize which are the topics of national interest, and they actively go and create these partnerships with the top companies and top academicians in the country. Now, this has been happening for some time. And the idea is not that every investment and every projects, they have 100, 200 plus programs now have funded activities, that everyone will be successful, but there will be a failure rate. But through this mechanism, there will be a positive externality that the whole innovation engine and ecosystem thrives and flourishes. So they have been using the NMITLI program even for SARS-CoV-2, for development for antibodies, with commercial players like Bharat Biotech, and with academic institutions like National Center for Cell Sciences. Also for the development of vaccines with Bharat Biotech. So this has not been only used in the past for TB and diabetes, but also been used in the SARS-CoV-2 platform as well. The success of this is still to be fully seen in terms of having blockbuster products, but it creates a very positive environment and research and development capabilities in the ecosystem. Next slide, please. So lastly, I wanted to highlight that there are a lot of challenges and a lot of areas still which India needs to work on to strengthen the public-private partnerships and the policies and institutions which foster them. So the first one is that there have been some lights of positive policies around private sector, which have been driven more by individuals, not so much as by institutional mechanisms and policies. So how to have governance structures at the national level and the state level, which really have a comprehensive private sector policy roadmap, and institutionally work towards creating this ecosystem is important. So it's not driven by individuals, but it's driven by the system. Um, Also, having regulatory frameworks and standards which are seamlessly implemented is important. We have areas of under-regulation, over-regulation, partly because there is no policy roadmap to guide it. We also need a lot more data evidence to sort of support this. Otherwise it'll become about individuals' beliefs and mistrust. And lastly, we need to strengthen the government's ability to purchase and execute purchase from the private sector. That is a state capacity which needs to be built up at the state level strongly, and at the local level at the cities and rural area as well. So thank you. That's all from my side in this presentation.
Thank you so much, Amrita, for this very rich presentation. We do have a couple of questions coming in from the audience. Some of them quite robust, multi-layered questions. I am looking at the time, so I am going to be a little bit selective. We will have another time later in our webinar to have another Q&A. So hopefully we can get to these additional questions in the later as well. But one of the questions that came up is related to how do you ensure that PPPs do not further marginalize certain groups or populations? I guess this might come from the perspectives of private sector being driven towards profitable ventures, maybe. So do you have any guidance or insights around striking a balance between private sector's gain and also public sector's interest to provide for its people? I do think about, for example, the case that you gave just now around the investments in drug development. I wonder, maybe elaborating on that would be helpful.
One, I have to say that private sector is not the solution for every problem. So, in remote places, in lower income states, I find it hard to believe a market will develop and the private sector will not, will be able to fulfill it. So I am not saying that the private sector is the full solution. It is a solution for many contexts. The second thing I would say is private sector is very varied. When I'm saying private sector, I also don't only mean the for-profit private sector, but there's also a not-for-profit private sector. And there are different motivations for each. Within the private sector, also there are small-scale private sectors which are very embedded in the local community. And there are large private sectors which are funded by private equity players, which have very different motivations. So I think the source of financing for the private sector completely changes its behaviors and its motivations for how it behaves, vis-a-vis the problem. And in terms of the pharma example, which you asked me, I think that also comes to the partnership and financing arrangements. For example, in terms of vaccines, right now in India, there's a dialogue between the large vaccine manufacturers and the government of India on how this manufacturing will be used for the Indian population versus the global population. And part of that has to be also done with financing arrangements and then policy dialogues. So I think the question becomes that sometimes when when it's the situation where solutions can be found between the public and the private sector, how to create a win-win solution between the two. And that's an art which is very hard to manage. Because governments change, individuals change, and the private sector managers also change. So it becomes an institution, again, it becomes about individuals and not an institutional process for creating and updating those contracts as they need to happen in future. So I think that mechanism needs to be put in place for this to work well over time.
Thank you for that, Amrita. I think institutions establishing public-private dialogue, first and foremost, seems to be quite critical. And India, given both fragmented public sector and also private sector is attempting a couple of different avenues to facilitate that dialogue and coming up with unique solutions where there is an avenue for leveraging the private sector. I think that's really interesting to think about, as in the technical guideline also it talks about institutions, and I think one of the key next steps as the policy is adopted is to set those mechanisms for consistent public-private dialogue. And looking for these opportunities, I think, is a topic that's of interest, and I think maybe the next speaker can talk a little bit more about that. I'm excited to introduce Monisha Ashok from USAID's Center for Innovation and Impact. As market access advisor, she supports the agency's effort to introduce and scale up global health innovations in low and middle income countries. With a deep passion for and focus on global health and economic development, she has recently been designing and standing up multi-stakeholder initiatives focused on value-based care and also blended and innovative financing. This might be a term that is maybe new for some, and hopefully Monisha can give a little bit more insight around that. So she's here to speak on the more nuts and bolts on the financing options available for engaging with the private sector, highlighting the frameworks and tools that the agency has created and tested in the last few years. So Monisha, if we can have you on screen, on video, the floor is yours.
Great, thanks so much, Sayaka. Can you hear me okay?
Yes, I can hear you very well.
Great. Well, thank you so much, everyone, for inviting me today and for giving us this opportunity to present some of our work on private sector engagement and innovative financing. And we'll be sharing some more global experiences today, somewhat similar to what Amrita just presented in the Indian context, but some of those same kind of PPP models we've tried to apply in other countries as well. So really looking forward to also learning from you all and the Indonesian experience and for our Q&A discussion later today. So if we could go to the first slide, or to the next slide, great. And so as Sayaka mentioned, I am with USAID in the Center for Innovation and Impact in the Global Health Bureau at USAID. And we are focused on applying private sector or business-minded approaches to accelerate the development and introduction and scale up of global health interventions. And we typically focus on innovations like new technologies or products or services. And so we do that through kind of three main ways. So one is catalyzing innovation. So running grand challenges, for example, to open source new ideas and new innovators, and then providing support to them to scale up. The second main way is through market access, or really the strategic planning and market shaping. So either addressing the supply side barriers or the demand side barriers to introducing and scaling up any new innovation in a lower middle income country. And then finally, some of the cross-cutting enablers like digital health and human-centered design that are often more prominent in the private sector, and thinking about how can we then bring that to some of the public sector contexts that we work in, along with brokering some of the private and public sector partnerships. If we could go to the next slide. And so today I'm really going to focus on innovative financing. And so to make that case, as we know that the global health community is, while making great progress, is still far from meeting all of our ambitious health goals, for whether that's the Sustainable Development Goals or the now universal health coverage goals across both infectious diseases and non-communicable diseases. And so we feel really strongly that we need new innovation to improve access as well as improve quality of care, as well as affordability, really. And not only new innovation, but also market access to meet those health goals. And this is challenging given just the financing that's required for that. And development or donor assistance has been plateauing over the past decade. And while many governments have really ramped up their domestic resource mobilization, and I'm sure Indonesia has done that as well, there's still a large financing gap. So globally, it's around $130 billion per year, and that's projected to triple to $370 billion over the next decade. And that was estimated even before COVID hit. So we can all only imagine how much greater the health financing gap is today. And so we really need to find new investment in global health innovation. So if we can go to the next slide. Great. And so one area that we could potentially find new sources of investment is in private capital markets. And so private capital and partnerships could potentially help fill this health financing gap and accelerate progress to our goals. Mobilizing just 0.5% of private capital markets could fill the entire health financing gap. And the private sector not only brings resources, but expertise as well. And so we're heartened by the promising growth in economic and social investing and socially responsible investing and impact investing. But we've noticed that health tends to lag behind some of the other development sectors like energy or agriculture. And we find that private investors, perceive a higher risk in health and sometimes can be more reluctant to invest in health. So if we could go to the next slide. But there's many different ways in which we can engage with this private sector and try to mobilize more private capital or resources for our health goals. And so there's this mix of both social and financial interests, depending on the source of financing. And so, traditional development assistance, either from a donor or from a government, tends to be in grants with no cost recovery. And all the way to the right, commercial investing, so whether that's venture capital or private equity, tends to be, really focused on the financial return. So cost recovery plus a sizable return on investment. But there's quite a wide range in the middle, everything from kind of conditional or catalytic funding, where donors or governments can use their grant capital more catalytically to try to bring in some of that private capital. And so some of the ways in which the donors or governments could do that is to think of ways to offset risk and or to enhance the return on investment in order to bring in those private investors who otherwise, may or may not invest in health. And so a few examples are a donor or government could provide a first loss guarantee to an impact investment fund in order to provide that base to ensure that there aren't significant losses, or if the fund does great, then to enhance the returns for those private investors. And that can help also maintain an impact focus. So one of the questions to Amrita was, how do we make sure that the private sector does not only focus on, say, the wealthier populations in, say, urban areas? How can we try to get them to focus on, say, more vulnerable populations or more rural areas? And the larger that this kind of first loss is, then the more it can absorb that risk and maybe extend the types of investments that these private investors would be willing to make in bottom of the pyramid or vulnerable populations, or maybe even more rural areas that they wouldn't otherwise. A second example is providing a loan guarantee. Again, Amrita just spoke about, working with government banks to provide working capital to some of the health clinics, especially in rural areas that have been hard hit by COVID. And so this again could be providing a loan guarantee to any kind of local bank to provide debt or loans to these health enterprises to continue operations, pay their health workers, and basically keep the lights on. And then the third example here is, how can we incentivize the private sector to invest in the health commodities or products that we care about? And so they may not be willing to manufacture a new drug for a vulnerable population if there isn't an upfront purchase commitment. And so using advanced purchase commitments or volume guarantees or price guarantees, there's different ways of kind of incentivizing the private sector manufacturers to make those investments in the health products that we care about. So these are just a few different examples of the ways that governments or donors can engage the private sector to mobilize private capital and resources. So if we can go to the next slide. And there's a wide range of innovative tools, financing tools that can help leverage this private capital and increase effectiveness. And so this, again, the private sector not only brings just resources, but can also help improve efficiency or effectiveness and increase sustainability in the long run. I won't go through all of the examples of the innovative and blended financing tools that are available. If you are interested in learning more about these, please go to the USAID CII website, where there are public goods that explain all of these different types of tools. And they range from providing guarantees to providing debt swaps or debt buy downs, investment funds, insurance, more flexible forms of seed funding or more flexible grant capital, outcomes-based payments, development impact bonds, which I know that there's going to be more in the next presentation, and then or co-funding between the public and private sectors. And if we could go to the next slide. What a lot of these innovative or financing tools have in common is this concept of blended finance. And this is using the public or philanthropic resources from a donor or from a government to try to mobilize new private capital for health outcomes. And so this can help overcome some of the barriers for private capital flowing to some of the low and middle income country markets that we care about. And so a traditional grant like that USAID does is providing a grant to an implementing partner, which could be often is a not-for-profit organization that provides direct service delivery to people, and then supporting them to ensure that they are meeting their health outcomes. In a more blended finance model, USAID could provide that same kind of grant through a blended finance instrument. And this could then help mobilize partners to provide additional grant or equity or debt. So again, as an example, if USAID provides a loan guarantee, then the partners could provide more loans or debt. And this blended finance instrument then could funnel the combined additional resources to those implementing partners to enable health outcomes. And so again, in this loan guarantee example, USAID could, if USAID is providing a loan guarantee, a local bank would provide additional debt, and then this entity could then extend more loans to higher risk borrowers or health clinics, for example, that are hard hit by COVID. So if we could go to the next slide. And why do we want to pursue some of this is not only does blended finance increase the funding or resources that are committed to health outcomes, it can also improve sustainability and stimulate innovation and help develop some of these local capital markets. So in the loan guarantee example, a local bank may be risk averse and not willing to lend to healthcare clinics as borrowers. They may not know how to do the know your customer process. They may not be aware of how to assess the business model of these health clinics. But if USAID or the government were to provide a loan guarantee and maybe some training or technical assistance to the local bank on engaging with these health clinics, then over time, maybe the local banks would actually start lending to those health clinics on their own. And so that sort of example could help develop the local capital markets and increase sustainability of the entire market over time. And so there's kind of multiple benefits of blended finance. If we could go to the next slide. Great. And again, available on the USAID CII website is our blended finance roadmap, which outlines a 6-step process in trying to identify what's the appropriate blended finance opportunity for health outcomes in a specific country or state. And so the steps are first trying to identify the country archetype. And Indonesia is already quite advanced in terms of having a robust private sector and an interest in PPPs, as we can tell from this webinar. And then depending on, and there's a framework for how to assess how developed the private sector is in a particular country or state. The second is trying to define the health issue. Is it that health clinics don't have enough funding to pay for their health workers, for example? If they are getting paid from a national health insurance scheme, are there delayed payments from the government, and hence they're not able to pay their health workers, or they're not able to buy their medicines on time and their stockouts, for example. So really having a clear understanding of what the health issue is. And then third is understanding what those financing challenges are. Is it that they don't have enough working capital to keep their continuity of operations, or is it that they need a new capital investment to expand their infrastructure? They're trying to if they have one building in the health clinic, they're trying to build another building, or they want to expand their service offerings, or just understanding what are their financing needs and challenges. And then fourth is just evaluating the different blended finance options and the potential for blended finance overall. Like, will it actually be sustainable? Will this bring in additional resources or expertise? Who are the existing private players? Like, is there a local bank that could provide financing in this case? And then shortlisting what are the appropriate blended financing instruments. So this could be a loan guarantee, like I mentioned earlier, or a number of different types of blended finance instruments. And then finally, this was tailored for USAID, but could be applicable more broadly, is to think of the role that USAID or donor or government would be playing in this transaction. Who would we provide additional training, technical assistance, monitoring and evaluation? What kind of support do these players need for this transaction? And to give you a more concrete example, if we could go to the next slide. So this was a model that we developed for one of our partner countries in Africa. And it was basically a revolving working capital fund for faith-based organizations. And so this country has a large number of faith-based organizations that provide health services, particularly in rural areas. And they were facing delays in getting paid from the national health insurance program. And so in this model, USAID and other donor agencies would first provide a guarantee to capitalize the loan to a local commercial bank. And so we capitalized 50% of that loan. Then the local bank, in this case, would lend that capital to a working capital fund. And in this case, it was set up to be an evergreen or revolving fund. And then that fund would provide loans or debt to local hospitals and health clinics. And over time, the hospitals are able to repay those loans back to that revolving fund that can recycle it to other hospitals and clinics. And to make sure that the hospitals have some stake in this, they also had to deposit a fixed amount in order to sign up to be part of this facility. And the hospitals, once they got paid from the National Health Insurance Fund, were able to then repay this revolving fund. And in addition, USAID also worked with another implementing partner to provide technical assistance and training to improve the financial management of these hospitals and health centers so they could understand how to manage their cash flow and how to repay debts over time and all of that. And then there was to further maybe complicate this a bit, over time, if these health centers were able to meet certain health targets, like if they were able to improve their quality of care, then USAID would also then do a debt buy down. So in the interest rate that they would pay would go down over time if they're able to show that they could improve their health outcomes. And so this seems complicated, but it could be replicable in other countries and potentially in Indonesia as well. And I'm sure that USAID Indonesia mission or the HP Plus team would be happy to brainstorm similar models like this. And if we could go, I believe, to the last slide. Great. So overall, CII mobilizes these kinds of models to bring in more private capital and private partnerships. And so a couple other examples are the Utkarsh Development Impact Bond, which focuses on improving the quality of care for maternal and newborn health in Rajasthan, India. And so in this model, a foundation, UBS Optimus, provided the upfront investment to implementing partners to improve the quality of those services and clinics. And that is verified independently. And if the targets are met, then USAID and Merck for Mothers repay UBS Optimus that investment with a return. Another initiative that USAID or CII manages is the Maternal Outcomes Matter initiative, and this is a partnership with the Development Finance Corporation and Merck for Mothers and Credit Suisse to provide a combination of debt and grant financing to private sector companies. And so again, if a company is not ready to take on full debt, then a combination of grants and debt could help offset the risk profile of that company. And if you're interested in learning more, then our website has, as I mentioned earlier, the Blended Finance Roadmap, as well as another report called the Unleashing Private Capital Report that outlines some of the barriers and opportunities to increase private investment in global health. If we could go to the next slide. Great. And that concludes my presentation. Thanks so much.
Great, thank you so much, Monisha. You've teed up very nicely to the next presentation. So we're going to go right into that, and then we will have a little bit of, hopefully, some time later still. We're running a few minutes behind, but still have a little bit of time to answer questions. And thank you so much for everybody putting in good questions in the Q&A box in the chat. So, we learned a lot from you, Monisha, around the unique tools and approaches that USAID is leveraging. That could be something that the Indonesian colleagues in the audience may consider applying, or to work with USAID to apply in the Indonesian context. So in the last slide, Monisha mentioned about Development Impact Bond as one of the innovative financing tools available. So to hear more about the practical experience of designing and implementing these financing tool, we have Dr. Adesh Chaturvedi as our third speaker. Adesh is the in-country team leader for the Utkarsh Development Impact Bond, managed by Palladium, that Monisha just mentioned, utilizing the innovative results-based financing mechanism to engage investors to provide upfront capital to improve the quality of maternal health services provided by private sector clinics. So, Adesh, please go ahead and share your experience on this Development Impact Bond, or DIBS, its benefits, challenges, and your thoughts on how other countries like Indonesia could take this up. And hopefully we'll be able to see you on video as well. Adesh?
Am I audible to all?
Yes, I can hear you now.
Okay, that's great. So thank you, Saika, and I would like to first of all, thanks to Indonesian government to facilitate and host this important webinar, and allow us to share our learning and experiences to the larger community. And I'm really glad that my previous speakers, Amrita, and Monisha has talked a lot about private sector, and also particularly about Utkarsh. So my work is a little bit easier now. So thank you. So I would like to share our experience of Development Impact Bond. Next slide, please. So Development Impact Bond is basically now it's a talk of the town, and people are increasingly talking about this blended finance mechanism, which is really an innovative finance mechanism. Next, please. But other than the finance mechanism, the impact bond has a beauty of a sure short outcome which is to be achieved by the implementing agencies. So I would here throw some light on facts and philosophy of Development Impact Bond. Next slide, please. So how does Development Impact Bond work? So DIB in short form, basically when a private investor provide working capital for a set of interventions and are repaid with the return by outcome funders if pre-agreed results are achieved. So outcome funders are paying back to investor only when the pre-agreed results are achieved. So the crux is that. And the what is innovation? Number one, the financial mechanism is the innovation, and what is the guarantee of payment is that pre-agreed outcome results are achieved. So there is an investor just in a mechanism. I would like to disclose it again. So there is a investor who basically provide upfront working capital to the implementing partners, to the agencies who really execute the program at the ground level. And once they achieve the pre-agreed outcomes, then there is the independent verification agency, usually hired by outcome funders. And after the successful result of verification agency, the outcome payers pay back the money to investor. So investor get its principal amount plus some additional amount, so that it run the program. But here the entire DIB is not explained. In all these things you will find a middle circle, elliptical shape, which is the implementation manager. Implementation manager is having a very crucial role here. And I was listening to Monisha, she has talked about the investor gives money to implementation manager. Investor gives money to service provider, the executive agency, but it gives money through implementation manager. So implementation manager's role is to manage the fund, establish a close collaboration, contacts and communication between investors, implementing agencies and outcome funders, and also verification agencies. Its role is to keep close eyes on the performance, timely execution of the program with the quality background, and also how the outcomes are achieved on a timely manner. So the role of implementation manager here is a really a crucial role. Next slide, please. So the beauty of this innovative finance mechanism is when outcome payers, like in this case USAID and Merck for Mother, when they pay money, usually in grant funding they pay money for input, process and all. But here they are not bothered about input and process and the failure of initial things and all. They are just concerned about the outcome. If outcomes are achieved, they will pay back money to the investor. So the risk shift from zero to the end. Next slide, please. So here I would like to tell more about the institutional mechanism. As I mentioned, USAID and Merck for Mother are the outcome funder, and uh, Hindustan Latex Family Planning Promotion Trust, HLFPPT, and Population Services International, PSI, these two are the implementing agency who are implementing the program at the ground, and Palladium is the implementation manager. And we have UBS, United Bank of Switzerland, Optimus Foundation is the investor. So we have two investors here. UBS is the a large investor, principal investor, and Palladium, HLFPPT, and PSI are also co-investor here. So our target is to improve the facilities, 360 private healthcare facilities on a certain standard. And at the end of the project plus 2 years of the impact period, so total in the period of 5 years, we would impact 600,000 pregnant women with the quality of services, and we would be able to save 10,000 lives of neonatal and pregnant women collectively. So the total outlay is $8 million plus $1 million is for the verification agency, which is Mathematica in this case. Here I would like to emphasize, you can see the flag of India and government of Rajasthan is written here. So if you see initially, you will not find the place for the government in this institutional mechanism, but government is there, and government is working as a non-executive partner here and having lot of influence to play in this entire development impact bond, because the policy and programs of government make lot of difference in terms of and growing up of private healthcare facilities. So their policy can increase the footfall, their policies can decrease the footfall in the private healthcare sector. So the government is, though it is here now a non-executive partner, but having a lot of important role in this entire DIB and its success. Next slide, please. So when we started DIB, we were having the challenges. Private health sectors are the, they are small enterprises. They run their hospital with their own money and resources. So there was a challenge of improvement of quality services. There was the challenge of understanding the importance of quality, and nobody is there to guide them, to handhold them, and to go with them to run the quality product in their day-to-day clinical life. And again, there's a disconnect between government and private sector, because government and the private sector are working in silos, and there is no, a good functional collaboration and connectivity, as my previous presenters have also mentioned about that. Here I would like to clarify two things. Small healthcare organizations are not that small, which we are understanding. These are the up to 100 bedded full-fledged facility. And Utkrisht Impact Bond is working with those SHCOs who are having maternal and child health services at their hospital, and at least 10 deliveries per month, including cesarean and neonatal care services. Next, please. So when we started this thing, we asked the questions to us that what is the solution to this problem, to the challenge, like improving quality of care. And we have these many questions, and we found the answers which were favorable to implement such innovative innovative project by involving private sector. Next slide, please. So what we do under Utkrisht? So we support the facilities to prepare for accreditation under two schemes. One is National Accreditation Board of Hospital Systems and Patient Safety, and second is the Neonatal and Maternal Healthcare Improvement, which is called Manyata. So Manyata certification. So we first map the facility, and then based on the Utkrisht criteria, we do the baseline in these private healthcare facilities. We debrief the gap analysis against the standards of NABH and Manyata, and we do the MOU so that the owner of the hospital, private hospital, can come on board. And then we provide a training program, hand holding support, monitoring, data management, MIS, all those things, clinical support to all the hospital staffs, right from the hospital owner, doctor, gynecologist, pediatrician, to the guard of that security guard of that hospital. So all the chain are trained on this verification, and then we facilitate the verification. So this is a cycle of 6 months. So every 6 months we engage new, every 3 months we engage new facility, and every 6 months the few facilities graduated from our pool, but they still are in contact with us. Next slide, please. So I spoke about two quality accreditation. So one is the Manyata, which is run by a professional body of gynecologists, which is called Federation of Obstetric and Gynecological Society of India, to ensure all pregnant and lactating women should receive respectful quality maternity care. And another one is National Accreditation Board of Hospitals and Healthcare Provider, which is a larger comprehensive initiative led by Government of India's Quality Council of India. So we are running two standards at the parallelly same time jointly. It's a joint quality standard under Utkrisht. One is the government led quality standard, and one is the professional body led quality standard. Next, please. So our job is to prepare the facility for 50% level of all NABH chapter and 70% level of all FOXI Manyata chapter. But so overall 26 standard and 260 objective element. But we, apart from 50 and 70%, Utkrisht has gone beyond the payment outcome metrics and supported SSCOs for actual Manyata and NABH accreditation and certification. Next, please. So this is the coverage of Rajasthan, of Utkrisht program in Rajasthan. So we are working with currently around 344 hospitals. 360 is the base limit, and we have touched over 200,000 deliveries so far. As I mentioned, the commitment on quality of the Utkrisht was beyond the contractual obligation. So out of 344 hospitals, 322 hospitals have actually received the Manyata certification, and around 150 hospitals would be receiving the NABH accreditation, because it's a long process to get the certification. But there around 200 facilities have already applied, and 51 has already certification in their hand. Next, please. So these are the pictures, more than the 1,000 words you can see, and you can see the before and after thing. Next, please. During COVID time, COVID has put the entire globe on knees. So due to COVID and the related lockdown, the majority of the private hospitals were closed. They were in a state of confusion, helpless. Nobody was there to help them out, and there was not proper communication from the on the clinical and the managerial protocols and guidelines to address the COVID related issues. So we considered this COVID as an opportunity to support the private hospitals and initiated several online. Our job was to provide on-site training, but we have converted ourselves into online training champions, and we provided online training on not only on COVID but also maternal and newborn care, hospital management, and all. And we also, disseminated government's fast-moving guidelines to them on a very crisp and effective manner. And realizing the importance of that, the morbidity and mortality due to lockdown and increased risk of getting COVID-19 infection at the facility level to the woman and newborn care, woman and newborn, we approached to our investor, and with the very small funding, we started the touchless maternal, newborn, and child health care services in the name of telecounseling cum telemedicine project. So here the photo which you can see is the prescription of telemedicine program. Next, please. So in all this experience, there are some beautiful pictures of Utkrisht program in action. Next, please. And also we got lot of appreciation from the facilities, and I'm really thankful to them that they took the pain to write us and share their feeling with us. Next, please. So sharing this all Utkrisht experience is basically leading towards why government should support private health sector. As Amrita has also mentioned, Monisha has also mentioned that there is always a fund crunches. There is always a financial a deficit in such things. And health being a very complicated sector has a lot of challenges. So I will talk little bit about what is the benefit of government to support health sector through this development development impact bond innovative model. Next, please. So private health sector, as mentioned, very fragmented across the globe. So private health sector is omnipresent from village to metropolitan, from a single person clinic quack barefooted doctor to a corporate hospital. Hence, their wide presence need to be tapped and equipped with the quality of care. I'm telling you, ensuring access is not enough. If we want to bring down mortality and morbidity, we need quality to address this. And DIB is a new innovative tool with blended finance mechanism. This ensures that the payment would be paid once outcomes are achieved. So it's not that the money is going into the drain. It's basically outcome based. And the private small healthcare organizations are more of a social enterprise, as I mentioned. They're serving the poor to middle class population in general. They have not been provided a proper support by any agency for improving their quality in logical manner, ensuring the approved and accepted standards. They are providing, but they are far from the quality standards. Next, please. So being a welfare state, government is accountable for every citizen regardless the place of getting services. Improved services at the private facilities is beneficial for the state as a whole in order to improve the health indicators in the state. And data, as Amrita has mentioned, getting data from the private facility is a challenge. So under Utkrisht program, since we are connected to around 400 facilities, we get the data on a regular basis, and we share this data with the government. So if government would run such program, definitely the data part would be enhanced and strengthened immensely, so that would be helpful in making the policies for the poor and reaching to the large person of the community. So government can adopt the tested and trusted approach of development impact bond for larger implementation and coverage, and which also de-risk health service delivery from for the government. So the logical conclusion of any development impact bond is the social impact bond, which is from DIB to SIB. When government plays as a role of outcome payer, then it is called social impact bond. Next, please. I would like to share a few learning very quickly. Next, please. So number one learning, and it, quality is not an easy thing to establish, maintain, and sustain. True for both private and public. I worked with public health sector also for around 15 18 years, and in last 25 years I have seen both the parts. So early engagement and continuous support is very, very important. We say, but I have experienced, particularly in this DIP, that rigorous monitoring, micro planning, mid course correction, gap analysis using data allow the targeted management. And verification process must be aligned with the quality accreditation process. It should not be in two directions. Active risk management and continuous improvement is the key of success. And to run any project successfully, project governance is very critical and very important. And government, if we are planning to engage government, it should be from the beginning. Regarding the sustainability of private health sector engagement, we would like to advocate that reputational recognition and reliability point of view, the sustainability is very, very important, because when a private health sector provider, a private service provider receive a quality certificate, so its reputation attached to that quality. And the private health sector hospital would take all efforts to maintain its reputation and reliability and the recognition to serve the poor people. Next, please. During COVID also, we have seen that uh, it's very important to innovate and respond quickly. And the beauty of DIB model, we have seen here that the DIB model, by virtue of its contractual focus on deliverable and results, provided complete flexibility to go beyond the budget line to deal with the pandemic by leveraging existing Utkrist resources without posing any administrative burden on outcome funders. Next, please. What is way forward? So my point is that private health sector is an ally of public health sector, not the competitor. Hence, it need to be engaged and supported by government for achieving the national health goal. Well-defined quality improvement and assurance should be preferred qualification by engaging the private health sector, not the not the infrastructural aspect. And COVID pandemic taught us the importance of touchless services, online, on-site, instead of on-site, online training, online telemedicine. And the quality improvement is very, very important, like infection control. Now it is talk of the town. So the DIP model has proved its uniqueness and credibility even during pandemic, not only to run the project efficiently, but also to address the larger issue of COVID. Next, please. So I would like to express my thanks to USAID for supporting this, to government of Indonesia, and USAID India mission, particularly Mr. Gautam Chakravarti, who is very much supportive to this Utkrist. And I would like to thank to my this team, very dedicated team, professionals from HLFPPT and PSI, and my Palladium team to support and run this successful program. And at last, I would like to really express my thanks to the small healthcare organizations, our partner, 344 partners, who have showed the a faith on us in the improvement journey. Thank you very much. I think I am well on time.
Thank you so much, Adesh. It's a very rich program, and it's great to hear more with a concrete example. I think there was a question as you were presenting. An audience member asked for an example and was very happy to see this Utkrist example coming through. So thank you, everybody, for asking your questions. We are running a few minutes behind, and we actually have quite a number of questions. So we most likely are not going to be able to answer them, but we will actually try to provide written answers after this webinar. Since some of the questions are quite robust, but we will try to handle as many as possible. There's maybe we'll start with a question for Monisha. based on the various approaches and tools that you had articulated. There was two related question that came through from the audience. One is around, blended finance is a great model to engage the private sector and lenders, investors, financiers. How does USAID or these specific project vehicles assess commercial feasibility in terms of the lender's perspective? You gave an example at the end of USAID supporting a local lender to lend out to local clinics while they wait for insurance payment. So can you speak a little bit, Monisha, to kind of how to assess terms? There was also a little bit a related question from an audience member around calculating the initial investment that will be provided by the investor, which really could determine the ability to pay of the government or the private party as well. So I wonder if, Monisha, if you can take that question for us first.
Great, thank you, Sayaka. You're really getting into the kind of technical details of structuring some of these innovative or blended finance deals. And so typically we do a due diligence process along with our private sector partners. So that could be the Development Finance Corporation if they're involved. It could be other DFIs. It could be the local banks. And so on the financial due diligence, typically lean on the support of some of our private sector partners. And so some of the things that we look at in terms of if it's a borrower, for example, a health clinic or hospital that's taking a loan from a local bank, would look at the longer term financial sustainability of that clinic or hospital. And so what's their business model? What are their current revenue streams? What is their profitability? What are their operational plans or expansion plans? What is their team like? Do we have confidence in their team? And then, if they're taking on debt, then would want to look at, do they also have other debt commitments? Do they have equity commitments? What's their debt to equity ratio, for example? Can they repay the loans in the terms? Typically, if we partner with the DFC, for example, they tend to have longer terms and can be, anywhere from 5 to 7 years or even longer. And so in that time horizon, do we feel confident in their ability to pay, or do they need grant funding to help cushion some of their revenue streams, for example, and what's the right mix of grants and or debt or equity? So it's kind of a lengthy process that we would go through, and it was very much vary based on the type of company that we're investing in and their financing needs, as well as the kind of health goals that we are trying to accomplish. So it would be very different if we are investing in a small, say, health clinic or enterprise versus a private equity backed health innovator versus like a large chain of private hospitals. And so each of them would have kind of different financing needs, and the structure and the terms of that transaction would differ based on those the different entities. But happy to kind of brainstorm that if there's a specific transaction or deal that you're looking at.
Great, thank you so much, Monisha. I think there's especially with these new innovative finance, blended finance, they especially in health, they are still relatively new. There's really not not many going around to say to simplify the message a little bit. And I think the fact that USAID has been doing this across the globe, there might also be collaboration that could be done with the Indonesian government and the stakeholders in pulling some of these capabilities and embedding it into to Indonesia as well by testing it and trying it out as well. I have a question for Adesh regarding Utkrist and the contract and the payment. There was a question from the audience around, how long the Utkrist life of the contract is right now. And in terms of payment, is it yearly, is it quarterly, or it depends on milestones? I think that's a really good question around, especially since this is a innovative financing mechanism.
Yeah, actually, since it is the word first development impact bond in maternal healthcare services, but I have also answered live there while Monisha was responding to the question. So it's a 3 years project. It started in 2018 and it would end in 2021 April. So and the impact period is 2 years post completion of the project, because quality, you can see the quality in a longitudinal manner. So the impact period would be 5 years. So the payment cycle basically is 6 monthly. As I mentioned, it's a 6-month cycle. So every 6 months, verification agencies, they arrive, they appears in the field, and they do the verification. Before that, we have to submit the list of hospitals with whom we have worked and whom they have reached to the a verification level. And then so every 6 months is the payment cycle, but only after successful completion of the verification process. If verification fails, nothing, zero. If verification pass, you get the money as per the things. So this is the payment cycle.
Thank you. Ajir, maybe we can take maybe one question from the audience that has come through, also in Bahasa as well.
Yeah. Okay, saya Kak. The question from one audience. I think this is for Adesh. Whether the financing you described that it directly from investor to private clinic, or it through from the government of India.
So this is the development impact bond engaging the private investors with the private facilities. So that's why it is the development impact bond. When government plays a role as outcome funder, so the investor is investing money, the private investor is investing money to improve the quality of private health facilities, and the outcome payers, in case of Utkrist, there is 2 outcome payer. One is the large pharma company Merck for mother, and one is USAID. So they are paying back money to investor. So if in place of USAID and Merck for mother, if government will pay the outcome payment to investor, then it would come it will be called as a social impact bond, DIB to SIB. So I would just like to put on record here that one of the state government of Maharashtra is very keen to implement the DIB experience in their government municipal hospitals. So they are ready to pay, act as an outcome payer and ready to pay money. And we have some private investors. So we are in a process of formalizing the SIB aspect in India also. So here government is under DIB. Specific to your answer, under Utkrist DIB, government is a non-executive partner and not investing any money directly, but their policies and programs supports the entire DIB immensely.
Yeah, thank you, Adesh. Your answer is very clear. I think Sayaka, can I ask one question to Monisha?
Sure.
Yeah. As you know, Monisha, although the Indonesian government has devoted significant resource to health services, For example, through Committed National Health Insurance, JKN, the resources are limited. If we want to take advantage some of the innovative financing instruments, as you mentioned before, what is the most important first step that we could take out with any stakeholders in Indonesia? Thank you, Manisha.
Great, thank you for that question. There's so many places to start, and I'm so encouraged that the Indonesian government is so interested in these public and private sector partnerships. And so as a first step, I would say starting with just a stakeholder convening, much like this. So I think you've already done the first step, is bringing the right set of public and private sector partners to the table and thinking through kind of what are the specific health challenges that you are focusing on. So within a state or a local context, the type of a health challenge that you're focused on, and what their financing gaps are. So I think just that problem definition itself could go a long way. And then once the health challenge and financing challenge are clear, then bringing in the local private sector actors. So that could be local banks, it could be it could be development finance organizations, it could be the Asian Development Bank, and it could be donors like USAID to the table to see what role each of them could play, and then bringing in the private sector financiers as well. So this could be if there are local impact investing funds, if there are local private equity investors who are interested in health, and so kind of bringing all of those stakeholders to the table to think through kind of what role each of them could play to address that particular health or financing challenge. These things take a long time to identify the problem, bring the right stakeholders to the table, and then takes many rounds of discussions to even come up with an initial blended or innovative financing model. And so just having patience throughout that process is also important.
Yeah. Thank you, Melissa. Back to you, Sayaka.
Thank you so much, Ajir. Maybe if I can have one last question for Amrita. In one of your concluding points, you had said that some of these there has been a lot of initiatives led by inspired individuals, and there's more work to be done around the systems. Now, of course, in the case of Indonesia, we are working around setting up these systems through the adoption of this new technical guideline around public-private partnerships for health services. But when it comes to really, I think testing things out, trying it seems to be the best approach because there's so many different approaches to doing PPPs. Do you think, what do you think is most, at least in the India's case, what has been most important? Is it, the policies in place, or maybe a call to action at the national level, or has it been more driven by individuals at the state level that wanted to do something innovative? How do you think the movement around PPPs have mobilized in India?
I would have to say this is a big challenge on how to make it happen at the systemic level instead of individuals. A lot of the inspired individuals in India have happened at local state levels. driven by local needs. For example, for dialysis, there are states which do not have dialysis capabilities in the government, and they had to partner with the private sector because there was no alternative. And their state had a huge need for dialysis. So I think the necessity has been the mother of invention, and some states have taken advantage. But there is a challenge. There is no acceptance of a public policy framework that one of the roles of health departments in states and the national governments is to work and empower and improve the performance of the private sector. The competition still exists. And since there is no team within the national government or the state government or the local government who's responsible for overall quality of care or overall financial protection for the population, then there is no, it becomes about that individuals have to go outside of the accepted norms that the government's focus is the government system to engage with the private sector. And once that officer or minister moves, then things go back to what they were before. So creating a policy framework for private sector at the national level and the state level, and then a governance structure whose responsibility it is to sort of engage with the private sector and with clear goals and definitions would help those inspired individuals to create sustainable efforts rather than sporadic efforts. I would say the legal framework is important. We do not have an explicit legal framework which looks for recourse when PPPs go bad, because we have to accept that all PPPs will not be successful all the time. So what is the legal framework which takes care of worst case scenarios will help promote PPPs?
Thank you so much for that, Amrita. I know I'm looking at the time, and I'm feeling like maybe we have to start wrapping things up. I do see that there is a hand raised, Dr. Noor. If you would like to put in your question into the chat box, we can make sure to follow up with you with a written answer. So please do contribute. Ajir, I wonder if we would like to move on to kind of our next and final section with a poll.
Ya, saya Kak, thank you. Terima kasih Bapak Ibu sekalian yang masih bersama kami di webinar ini. Saya mengucapkan terima kasih kepada seluruh pembicara yang sudah mempresentasikan dengan sungguh memuaskan dan menggugah kita semua untuk pelaksanaan kemitraan pemerintah dan swasta. Tampaknya memang bahwa ada banyak cara yang dapat kita pakai untuk memanfaatkan sektor swasta untuk keterlibatan mereka di bidang kesehatan. Inilah masa depan layanan kesehatan dengan sektor swasta yang dinamis dan tentunya diiringi dengan komitmen pemerintah melalui regulasi yang akan kita keluarkan. Saya sungguh antusias untuk melihat ke depannya bagaimana nantinya Kementerian Kesehatan bisa mengeluarkan kebijakan ini terkait dengan kemitraan pemerintah dan swasta. Bapak Ibu sekalian, selanjutnya saya ingin meminta Bapak Ibu para peserta dalam jajak pendapat kembali. Jadi nanti sudah terlihat di layar Bapak Ibu sekalian, menurut Anda di mana ada potensi untuk membentuk kemitraan pemerintah dan swasta dalam layanan kesehatan. Jadi jawaban yang pertama melalui pemberdayaan masyarakat, kemudian di area layanan kesehatan primer, kemudian layanan rumah sakit untuk penyakit khusus, kemudian teknologi kesehatan, apakah itu nantinya sistem atau aplikasi, dan hal lainnya di luar ini. Mohon sebutkan apabila ada hal lainnya yang seharusnya penting bagi Bapak Ibu sekalian. Silakan. Silakan memberikan votingnya, baru 15% yang mengisikan jawabannya.
Yes, looking forward to getting everybody's ideas. Of course, please do share your thoughts over chat as well. Please share with all panelists and attendees of any ideas you may have. Pak Ajir, I'm very excited. We have pretty much maintained close to 110 participants throughout this webinar, which is fantastic. Thank you so much, everybody, for your engagement. We hope that we'll, I think there's been a lot of interest in the presentation, the speakers. We'll also make sure to, I think, Pak Ajir, we should follow up with the link of the speakers. And maybe we can also translate.
Give the email, I think.
Yes,
maybe give
some
the
contact
email.
information, and we'll, of course, make the webinar recording available, and also the presentation available. Maybe we should we can try to translate it into Bahasa as well, so that the content is readily available.
Ya, Bapak Ibu sekalian, nantinya presentasi ini akan kami share, kami unggah. Untuk yang pertama saat ini memang masih dalam bahasa Inggris, kemudian nanti akan kami terjemahkan ke dalam bahasa Indonesia. Apabila Bapak Ibu sekalian masih ada pertanyaan yang memang belum sempat kita diskusikan, silakan menanyakan di kolom Q&A atau bisa disampaikan pertanyaannya langsung nanti. Kami akan share email dari teman-teman tim di SG Plus dan PPJK. Terima kasih. Over to you, Sayaka.
Great. Thank you so much. Maybe we'll close the poll at this point in time. Hopefully everybody had a chance to submit your selections based on the ideas and concepts that you've gotten during this webinar. Hopefully we'll get the results loaded up very soon. Again, thank you everybody for participating, and of course, thank you so much to all the presenters today. Fantastic, really interesting. A good mix of interest in primary healthcare services, expansion through PPPs. It seems as if the presentation from Adesh is maternal newborn health partnership might have inspired some of that. And also, of course, health IT remains always an area of investment and potential scale up where private sector has been leading the way. So collaboration between the public sector and the private sector to use technology to improve quality of care, that seems to be a great area of exploration as well. Thank you so much for everybody in participating in the poll and for sharing your thoughts as well. Of course, P2JK and HP Plus remains very much interested in working with all of you in creating these ideas. So please do reach out to us whenever as a follow-up to this webinar to discuss further. And so I hope you found all of these presentations enlightening. I would like to again express my gratitude to all the panelists for sharing your thoughts and experiences. It's clearly evident that your experience and knowledge and creativity were the right combination to have a very stimulating webinar. So thank you, everyone. For presenting, and also everybody in the audience for your active participation as well. And so now I would like to request Pamela Foster, Health Office Director from USAID Indonesia, to deliver closing remarks. Hopefully you can highlight a couple of areas of interest that resonated with you as well. Pam, over to you.
Great. Thank you, everybody. And I agree. What a fascinating discussion and presentation. So first of all, again, for USAID, a huge thanks to all of the distinguished speakers for participating and for all of you dialing in across countries and time zones and continents, and for a really robust discussion. Certainly, of course, thank you to everybody for sharing the lessons learned and the experiences from India. And of course, to my colleague and friend Ibu Yani and Pedro J. Ka and team for being willing to look at how we can adapt and take the best of this, but make it work for the Indonesian context, right? While there are some similarities and some things we can learn, of course, Indonesia has its own unique trajectory and systems, and having a chance to think through this and think about what this means for Indonesia, I think, is a wonderful opportunity. Certainly, we learned from India's partnership experience that innovative financing has really enabled this to take root and to grow. And I was heartened to hear about the concrete impact that the public-private partnerships have had on maternal and newborn health services. Mothers are particularly gaining improved access to better quality services for themselves and their families. And this is what we all want for women everywhere in the world. But the way that we can leverage dynamism from the private sector to do this is always exciting to hear. Adesh, thank you so much for giving us a much deeper look at the development impact bond and your experience with that. The stories and learning from these innovative results-based financing mechanisms is still being written, but it's delighted, we've been thrilled to watch it unfold and to see how it continues to take off. Certainly, in any approach, right, achieving health outcomes at scale is going to require a whole of system approach and many, many partners. So these innovative partnerships and financing tools allow us to really get a better handle on what role each partner can play, what we bring to the table, how to align all of these interests and skills and the expertise, and then, of course, have them contribute to better health service outcomes. The efforts in particular of Pedro J. Ka and the Ministry of Health in launching the technical guidelines to the public-private partnership is a critical foundational step and very exciting that will help us all look together at what the ministry is expecting and how all of us align behind this to improve health outcomes in Indonesia. I was fascinated by Amrita's presentation on the coordination mechanisms and seeing how we can facilitate dialogue between the public and private sectors. These conversations, these living dialogues, and the trust that these build will be central to the implementation of the recent PPP non-infrastructure technical guidelines for the health sector. And having some experiences to draw on will be useful for us in sort of shortening the curve, as we say. I think, as Sayaka, as you noted, what great questions and participation from everybody who has joined this. And we clearly, if we had more time, we could keep this going. So I look forward to us, continuing this dialogue and getting responses back to people when we can. I think that we all see that for every step forward, 5 more questions come up. So I think that we still have our work cut out for us, but the next steps and the future for this in Indonesia are very promising. As many of you already know, USAID has focused on elevating and enhancing the private sector engagement over the past few years. We continue to place greater emphasis than ever before on consulting, strategizing, and working with the private sector, having them actively engaged as a partner for the greater scale and sustainability of health outcomes. We think that this is a crucial pathway not only to respond to the needs of the Indonesian citizenry, but also to make sustainable, lasting improvements in the health sector. And we're delighted that we saw several of this come through in Monisha's presentation. There are many, many ways in which the governments and donors together can unlock capital through blended financing mechanisms. And we, of course, here in the mission are eager to continue supporting Indonesia's efforts in scaling up these partnerships. It goes without saying, but just a tremendous vote of thanks, PPJK and the Ministry of Health for hosting, coordinating, and the success of today's events. and then to all of the speakers and partners from USAID in Washington, from India, and then of course certainly the Health Policy Plus team for making this webinar possible. I'm looking forward to following the next steps, but for the moment, I would just like to thank you all again and wish you a very good day. Back to you, Siaka.
Thank you so much, Pam, and thank you again, everybody, for your participation. We look forward to staying in touch. Do reach out to us. Terima kasih. Have a good rest of your day.
Iya, terima kasih. Sayaka, terima kasih Pamela, Bapak Ibu sekalian. Kita bisa membuka kamera untuk kita berfoto bersama. We can open the camera. Yeah, to have a picture together. All participants, all panelists. Silakan Mbak Yusnita memimpin. Masih di mute Mbak Justina. Mbak Justina masih di mute.
Ya, terima kasih Bapak Ibu sekalian. Kita akan berfoto bersama. Nanti foto juga akan disebarkan. Saya akan memberi kode, lalu IO akan melakukannya. 1, 2, 3. Satu kali lagi. 1, 2, 3. Thank you very much.
Oke, terima kasih. Thank you very much. Terima kasih.
Terima kasih.
Thank you, Sayaka.
Ibu.
Thank you so
all
much.
of you. Thank you very much.
Thank you, Ibu Yani. Thank you all the speaker, Pak Ajir and Pak Sayaka, Ibu Anas, Pak Edi.
Thank you, Bu Yani, Mas Ajir, Sayaka, Mbak Justina. Thank you very much for the successful event. Thank you. Have a good day.
Have a good day. Oh, nggak ada chatnya. Gue nggak bisa nulis chat ya. Mbak Vanda, terima kasih.
Thank you so much, Ibu Vanda.
Adit, terima kasih. Mas Anto, Mas Lemi, Mas Vincent.
Congrats.
Ya, luar biasa karena tidak ada halangan sedikit pun.
Ya, smooth, seamless.
Ya.
Luar biasa.
Ya, puji Tuhan, alhamdulillah. Masih ada follow up. Kita harus merespon semua pertanyaan-pertanyaan. We have to respond to the questions that we are not erased in the webinar. So Sayaka, we still has a homework. But I really want to thank you, and then very relieved. Thank you so much. And then very sorry to Vanda that I maybe a little bit push you, and then also with the EO, the host, too much push from me, and then working so very quick. Yeah, but we see the results. So thank you, and sorry for unpleased words or arrangement or things. We also thank you to Mbak Stefana, who are not here. And okay, Mas Anto, thank you for your support.
Thank you, Mbak. Mohon izin. Yeah,
let's go have a lunch. Let's go have a lunch, and then all the bills built on Mas Anto. Okay. Yeah, thank you. Thank you, Mas.
Thank you. So yeah, to follow up with the question and answers, I think most of the questions from the chat has moved over to the Q&A box. So I hope if we keep the Q&A, we will be all set. But yes, we'll work on that. Hopefully the panelists wouldn't mind me bugging them for a little while longer to get some answers from them. So we can formulate a plan on how to distribute. But I'm very excited to have all these audience members and really good questions. Fred, with all these really hard questions, man.
Yes.
So, but it was wonderful to get everybody engaged. Hopefully, they found it to be interesting. So.
Yeah, I'm appreciate also to the host because the YouTube channel we are not using the P2JK, but they switch directly to their private YouTube. Then we share the YouTube link to everybody. Then maybe you said we'll tap in on that. And then later on, the host, Mas Lemi and team, maybe the YouTube channel, the YouTube recording can link also to the, we can share to P2JK, kita bisa share ke P2JK so mereka bisa masukin sendiri di dalam menunya mereka.
Oke, Pak. Oke, Sayaka and Mbak Justina, yeah, I will leave. Thank you very much. Yeah.
Enjoy your lunch. Enjoy your rest of your day.
Yeah.
It's been quite a stressful few days for you, I know, Anto. So hopefully the rest of the weekend is a relief for you.
Thank you, Sayaka. I'm sure you too. Okay.
Okay.
Yeah.
All right. Talk to you all soon.
Yeah. Bye.
Bye.
Adit, are you okay?
Adit, thank you so much for all your help.
Okay,
I'm still muted. Sayaka, have a great rest. Talk to you soon.
Yes.
Yeah.
No, now I have to like calm down from all the excitement.
Yeah. And then have a good rest. And then tomorrow we talk again, right?
Yeah, that's right. Yeah, it sounds like, I don't know, there seems to be something about chat and Q&A. So in the comments.
Don't worry. I've already told the EO, Mas Vincent, to recap all of the chat, all of the Q&A, and the recording, so we can have all that. So you can ask the speakers for questions, and then we can send back the answers to the participants as well. And we've already shared the material with them, so I think it's okay. I think everything is. I think everything's done, basically.
Okay. I'm just going to, great. I'm just going to write a note to our presenters. Okay, great. Thank you. Have a good
Bye. Have a good
day.
Bye.
Bye.
Have a good rest.
Bye.
See you.
Terima kasih, Mas Helemi, and then also Adit. Bye.
Bye.
Okay, thank you, Mas Vincent. Terima kasih banyak dan tim Easy. Great job today. Nanti ke depannya kita tektokan lagi ya. Keep up the good work.
Sama-sama Pak, Bu.
Terima kasih. Mohon maaf ya Mas Vincent, stres.
Oh iya Bu. Iya, nggak apa-apa Bu.
Oke,
ya, mohon maaf juga Mas, kita tektokan selama event ya, non-stop.
Non-stop.
Memastikan. Nanti kita tektokan lagi ya Mas ya untuk ini sisa apa? Laporan-laporannya sama pertanyaannya yang rekap biar dikirim ke kita.
Iya. Nanti setelah ini ada generate-nya, setelah recordingnya di convert, semua report untuk chat, Q&A sampai attendee list baru bisa di generate dalam format CSV nanti.
Ya. Sip.
Oke. Siap.
Selamat siang.
Terima kasih Bapak Ibu.
Banyak Mas, selamat siang. Kita undur diri
selamat
dulu.
siang.
Ya, terima kasih Pak.
Ya. Bye.